with Kitab Al-Fatih. Okay, all right, let's proceed.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Can everyone see my slide?
Yes.
Right, thank you. Okay, so my name is Nadira binti Muhammad Azhari. So tonight I will be presenting about approach to child with generalized edema. Okay, so just a little bit of introduction about edema. So edema can be defined as increase in interstitial fluid volume and also swelling of the tissue. So edema can be divided into localized edema or generalized edema. And there are a few terms that we are already familiar with. For the localized, there are ascites and pleural effusions. And for generalized, there is a term called anasarca, which is severe generalized edema. Okay, so for the causes of edema, edema can occur due to increase in capillary hydrostatic pressure or decrease in capillary oncotic pressure due to hypoalbuminemia or increase in capillary permeability. So in case of increased capillary hydrostatic pressure, it can occur due to increase in plasma volume, such as sodium and water retention in case of heart failure and renal disease. And it can also occur due to venous obstruction, for example, in case of liver cirrhosis. As for the decreased capillary oncotic pressure or hypoalbuminemia, it occurs due to nephrotic syndrome, liver failure, and also in case of protein malnutrition or kwashiorkor. And for the third mechanism, which is increased capillary permeability, it occurs due to drug-induced, such as calcium channel blockers, and it can also occur in burn and also sepsis. Okay, so for example of case scenario, 5 years old, previously healthy female presented with generalized swelling for 2 weeks duration. So how do we approach this type of chief complaint? So for the history taking, in history of presenting illness, first we need to elaborate about the presenting complaint, chief complaint. So swelling, we need to know the site or location of the swelling, the onset and progression of the swelling, the characteristic, either it is painful or non-painful, and associated symptoms, such as in case we need to ask, is there any fever, lethargy, vomiting, dizziness, headache, breathlessness, and rashes. And we need to also ask for associated symptoms of heart failure, such as paroxysmal nocturnal dyspnea and orthopnea. And in case of hepatic involvement, so we need to ask for any abdominal distension or any jaundice, any steatorrhea. And in case of glomerulonephritis, such as hematuria, and also in nephrotic syndrome, we need to ask about proteurine and oliguria. And we need to also ask possible complications, such as we need to ask possible complication of post-traumatic glomerulonephritis, such as, is there any episode of seizure? And then we need to ask regarding the exacerbation and relieving factors. So we need to ask whether the edema worsened on the morning and relieved by the evening, which is the characteristic of nephrotic syndrome. And then we need to ask also for the severity in case of, if we suspect the patient, we need to rule out for the presence of pulmonary edema, so we need to ask in terms of breathlessness. Other important history to rule out other differentials, we need to ask, is there any history of burn, recurrent chest infection in case if we suspect heart failure, and then past history of sore throat or skin infection in case of post-traumatic glomerulonephritis. So, and the next one, if there is any history ingestion of drugs, and then past history of recurrent urinary tract infection, and also history of blood transfusion, just in case we want to rule out hepatitis B infection. Okay, so for the post-medical history, we need to ask either the patient have any underlying medical illnesses such as congenital heart disease, IgA, and then is there any previous hospitalization with the same presentation? And then for the family history, we need to ask, is there any family history of renal or kidney disease, heart disease, liver disease, autoimmune disease, malignancy, and then is there any family member presented with the same illness? And then we need to ask regarding the feeding history. So we want to know if the child, whether the child might be malnourished, and then if there are any symptoms of feeding difficulty in case of heart failure in child. So the baby might have poor suckling, prolonged time to feed, and also sweating during the feeding. And then we need to also ask regarding the birth history, especially history of antenatal scan. So is there any abnormality such as renal agenesis? Okay, and then for the immunization history, we need to also get the immunization history. And then for the social history, we need to know either if the child is being neglected by the parents, so he or she might be malnourished. And then we need to also obtain other pediatric history. Okay, so back to our case scenario. So the patient has swelling which started at the preorbital area, then progressed to the abdominal, and then at the ankle. So 1 week prior to the admission, she went to the primary care and urine dipstick test was done, and it was revealed there is 4+ of protein, and then she was referred to the nephrology clinic. Otherwise, she also has history of weight gain of 2 kilograms, and she denied, and the parents deny history of fever, chills, upper respiratory tract infection, nausea, vomiting, hematuria, and also diarrhea. She also has no history of kidney disease. Okay, so after obtaining the history, moving on to the physical examination. So generally, if the patient come with swelling, what do we want to look for in the general examination? So first, we want to identify either the child is alert, conscious, or in respiratory distress, and then look for any dysmorphism in case such as we know that Down syndrome can be presented with congenital heart disease, which can also cause heart failure. And then we need to look for signs of cyanosis, either peripheral or central cyanosis, and then signs of anemia and stigmata of infective endocarditis and the stigmata of liver disease. And then we need to look for any jaundice and check for the capillary refill time and hydration status, because we know that if patient come to us with complaint of swelling, he or she might be dehydrated because of loss of fluid into the third space loss of fluid. Okay, as for the edema, we need to identify the site. We must remember that we must also do genitalia examination to look for scrotal or labial edema, and then we need to check either the edema is pitting or non-pitting. Okay, so for the vital signs, we need to obtain the blood pressure, respiratory rate, pulse rate, and also temperature. As for the anthropometric measurement, it is very important because we want to check either the patient has failure to thrive, and we need to know if there are any weight gain. And then for the respiratory examination on percussion, there might be stony dullness in case of pleural effusion, and on auscultation in case of also pleural effusion. Sorry, for the pleural effusion, there might be crepitation at the bilateral lower zone of the lung. And then for the CVS examination, we need to look for if there is any murmur. And as for the abdominal examination, on inspection, look for any gross ascites, abdominal distension, and any medusa. And on the palpation, look for any hepatomegaly, palatable kidney, and then on percussion, check for the ascites by doing fluid trill and shifting dullness. And then also we need to do neurological examination in case of post-traumatic glomerulonephritis, because hepatic encephalopathy can be presented with hyperreflexia. Okay, so for the, again, back to the case scenario, for the patient on physical examination, she has moderate abdominal swelling with ascites and also pretibial edema. Okay, so next, moving on to the third steps, which is the investigation. So for the blood test, we need to do full blood count to look for if there is any anemia, leukocytosis, or any platelet, and look for the platelet count. And then liver function test, because we want to check the level of albumin, because hypoalbuminemia can be presented in malnutrition and liver cirrhosis. And also we need to look for liver enzymes. And then for the renal function test, check the creatinine level, urea, and also electrolytes. And then we need to do lipid profile in case of nephrotic syndrome, where patient might have hyperlipidemia. And then coagulation profile, look for the PT and APTT and ABG, because nephrotic syndrome can also have metabolic acidosis. And then we need to do serum complement level in case of post-traumatic glomerulonephritis, where there will be low level of C3 and normal level of C4. And in case of serum, and we can also do serum alpha-1 antitrypsin level, because alpha-1 antitrypsin deficiency can also cause liver cirrhosis. Okay, as for the urine test, urine dipstick test to look for proteinuria and hematuria can be done. And then UFIM can also be done to look for red cell cast and pyuria in case of post-traumatic glomerulonephritis. Okay, so for the serology, streptolizin O antibody can be done in case of post-traumatic glomerulonephritis, and also we can do Hep B in serology test. For the autoantibodies, we can look for autoantibodies such as ANA, anti-DSNA, and also ANCA in case of SLE, because SLE can also cause nephritic syndrome. Okay, other than that, we can also do ECG if we want to look for the right or left ventricular hypertrophy. And as for imaging, chest X-ray, ultrasound, KUB, echocardiography, and nuclear scan renal DTPA can be done if the patient is indicated. And lastly, renal biopsy can also be done if the patient is also indicated for that. Okay, so for the case scenario, the urinalysis was done and she has 3+ of proteinuria but no hematuria. A renal function test revealed mild hyponatremia, and otherwise liver function test was done, total cholesterol was done, and triglyceride was done. And the patient was then diagnosed with nephrotic syndrome. And yes, that's all for the case scenario. And she was then managed as nephrotic syndrome, and she received IV 25% albumin and also furosemide, which is diuretic. She is also on fluid and sodium restriction and oral vitamin D supplement. After that, she was started on corticosteroid therapy, and she was discharged on day 4 of admission after everything is okay. Everything is back to normal. Okay, so that's all for the case scenario. So for the management of edema, first, when we need to first do the ABCD, maintain the patency of the airway, check the breathing, check the circulation to ensure everything is normal. After that, after the patient is stable, we need to do vital signs monitoring and also daily weight. Okay, and then for the supportive management, the patient, we need to advise the patient to bed rest, and also we need to do strict input and output chart and sodium and water intake restriction. As for the pharmacotherapy, diuretic can be given. So for the nephrotic syndrome, the management that can be given are diuretic, steroid, and also human albumin. As for the post-trap AGN, antibiotic, diuretic, and also BP reduction can be done. For the heart failure, we can give anti-failure medications and surgical or transcatheter treatment if indicated. And for the liver cirrhosis or liver failure, fat-soluble vitamin supplementation and antiviral therapy if the liver cirrhosis occur due to viral infection, and liver transplantation if the patient is indicated. So I think that's all. So in conclusion, when we have patient presented to us with generalized edema, make sure to do the appropriate history taking and physical examination and also appropriate investigation and manage the patient accordingly. Okay, so I think that's all from.
Any question from the others? I think something that I have always reminded all you students, whenever you do history taking, whenever you do physical examination, whenever you present, whenever you do investigation, always remember the 4 objectives. Always remember the 4 objectives. What are the 4 objectives of history taking? What are the 4 objectives of physical examination and presentation? So number 1 is to get to your provisional diagnosis. So provisional diagnosis. Second objective is to rule out differential diagnosis. And third, look for complications of disease. And fourth, to look for complications of management. So when you have a child with generalized edema, think what could be your provisional diagnosis and what are your differential diagnosis. And remember, differential diagnosis tu, dia contohnya if you think it's glomerulonephritis, kan? And you need to think, is it post-streptococcus or is it other causes of nephritis? Kan? SLE, HSP, hepatitis, is it because of drug induced, is it because of food and so on and so forth. If it's nephrotic syndrome, there are causes of nephrotic syndrome. Could it be primary nephrotic syndrome? Could it be secondary nephrotic syndrome? And what are the causes of secondary nephrotic syndrome? So you need to go through all those things in terms of the history. And then remember the third objective, complications of disease and complications of treatment. Kan? If you all have had sessions with me where I discussed about the pathophysiology of nephrotic syndrome, kan? So you should remember already there's 2 theories behind nephrotic syndrome, the classical or underfill theory and overfill theory, and both have different types of complications. One with dehydration and another one with fluid overload, and all those have different complications by itself. So look for all those complications of the disease and look for complications of the management as well. Look for complications of the management. Okay, all right. Next.
Doctor, I have question.
Ask the presenter. Yes.
Oh, okay. If let's say there is a case, a patient having nephrotic syndrome with underfill punya, macam patient looks dehydrated. Kalau ikut the macam mana? Patient dehydrated lah. So in term of management, do we need to give the patient IV fluid therapy?
Okay.
Even the patient look.
Okay, if the patient is nephrotic syndrome, how can a nephrotic syndrome with underfill theory looks dehydrated? How? What do you mean? Macam mana dia underfill? Macam mana what do you mean by looks dehydrated?
Sebab from what I understand, for underfill, all the fluid inside the vascular will be escaped out from the vascular towards the interstitial. So patient will present with gross edema, and then there will be oliguria. So, by that,
Okay.
I think the
So macam
patient,
ni. So basically in underfield theory, the patient will appear edematous lah, will appear edematous. But despite being edematous, there will be intravascular volume depletion. So bila intravascular volume depletion, if you look at the patient generally, the patient does not look dehydrated. So dia nampak edematous. But how you know the child is dehydrated? There's tachycardia, there's oliguria, the sodium may be a bit high. No, because this is yeah, the sodium may be a bit high. And then if you do echo, you see the left ventricle is a bit shrunk. You do chest X-ray, you see the mediastinum to be shrunk as well. So these are the signs that this actually tells us that the patient is actually under volume, underfill. Okay, if in this type of patient you want to give fluid, what do you think will happen? What do you think will happen? Okay, go back to your Starling forces. So the problem with this patient is severe hypoalbuminemia. Severe hypoalbuminemia affects your Starling forces. Reduced plasma oncotic pressure, relatively increased plasma hydrostatic pressure. And now you are giving more fluid. If you give more fluid, what will happen? You'll increase the plasma hydrostatic pressure further. You'll reduce the plasma oncotic pressure further. So what will happen is there'll be more fluid shift to the extravascular space. There'll be more fluid shift to the third space. There'll be more pleural effusion. There'll be more ascites. So you will not be helping the patient. So in that way, the treatment should be, and if the underfill, the treatment should be to get fluid from the interstitium back into the intravascular space. And how can we do that? How can we do that? You increase the plasma oncotic pressure. So how can you increase plasma oncotic pressure? Yes, you can give albumin, for example. You can give albumin. But that is only temporary. Kan? You still need to settle the proteinuria. And how you do that? By giving steroid and so on so forth. Okay, clear. Faham Tum Kalami? Right, fine. Okay, next.
Can you see my slide?
Yes.
Okay, thank you. Bismillahirrahmanirrahim. I will present about the chart with the change in the urine color. So, okay, normally our urine color it is clear with no turbidity, and the color is actually light yellow or almost colorless. It depends. However, the color can depend on the dehydration status. It can be very clear yellow, very light yellow, to very yellowish and almost brown. It also can change its color depending on the certain diseases, such as due to the it can be dark yellow, dark brown, or black. It can be Coca-Cola colored or red and pink urine. Okay, what are the type what are urine that can change its color? Urine can change into dark color urine. It can be pink, red, or Coca-Cola colored like this. One of the causes, it can be to the heme, in which when we do a dipstick positive stick, it can present with a dipstick positive for blood. The true dipstick positive is the hematuria, in which there's presence of the red blood cell in the urine. However, dipstick also can be false positive in presence of the myoglobinuria and hemoglobinuria. Myoglobinuria there is a breakdown of due to the breakdown of the muscles, such as in the status epilepticus, crash injury, myositis, and extreme exercise. This type also can present. There are also hematuria in hemoglobinuria, such as in autoimmune hemolytic anemia, GCSPD deficiency, malaria, and pyruvate kinase deficiency. Dark color urine can also be due to the non-heme that can present with dipstick negative, in which urine can be dark colored due to the hyperbilirubinuria. In obstructive jaundice, it can present with the tea colored urine. Also due to the ingestion of the beetroot, blue and blackberries. In the inborn error of metabolism, it can present with the black colored standing urine, which is alkaptonuria, and also due to ingestion of the certain food coloring. Certain drugs also can cause dark colored urine, such as rifampicin, metadopa, and chloroquine. The urine can also be turbid in presence of certain substance, such as protein in presence of a protein in proteinuria, in nephrotic syndrome, and severe UTI. Also can be turbid due to chyluria, such as in filariasis, lipiduria, in nephrotic syndrome, cells, pyuria and bacteria, and crystallization. Okay, in the case study, a 7-year-old boy presented with a bloody urine for 2 days. Okay, first we need to go through the hematuria. Hematuria, there is 2 types of hematuria, which is gross hematuria and macroscopic hematuria. Gross hematuria is a blood that we can see with the naked eye, in which gross hematuria can be due to the upper UTI or lower UTI. Usually upper UTI has a more darker urine colored, and lower UTI usually pink or reddish. Macroscopic hematuria usually is not visible. However, it is visible when we do UFM in presence of the more than 5 RBC per high power field on freshly voided and centrifuge urine. Okay, how hematuria can happen? Usually caused due to the three pathogenesis. Usually, first it is due to the structural destruction of the integrity of the glomerular basement membrane, usually caused by the inflammatory and immunologic process. It also can be caused by the toxic disruption of the renal tubules by the chemicals and drugs, and also by the mechanical erosion of the mucosa of the GUT by the calculi. Hematuria can be caused by two group. First is granular hematuria due to the granular causes. In the most common cause is the post-streptococcal glomerulonephritis, and next is the IgA nephropathy. There is also hereditary cause of the glomerular hematuria, such as in Alport syndrome and benign familial hematuria. Bear in mind, hematuria also can be caused by systemic disease such as Henoch-Schönlein purpura, lupus nephritis, and hemolytic uremic syndrome. It also can be caused by the non-glomerular hematuria. Non-glomerular, it's outside the glomerulus. It can be due to the neoplastic, such as the Wilms tumor, the most common renal tumor in the pediatrics. It also can be caused by interstitial disease, such as pyelonephritis, and ADPKD, autosomal dominant possessive clinical. Okay, and then it can also originate from the urinary tract, such as in the UTI, due to the stones such as urethrolytiasis, trauma, and foreign body. It also can be caused by vascular, such as in trauma, and due to the renal vein thrombosis and sickle cell disease. Hematuria also can be caused by the bleeding disorders, such as in hemophilia and thrombocytopenia, and others such as in drug-induced and menstruation. Menstruation is a false hematuria. Next, in hematuria, we need to ask about the urinary symptom. In urinary symptom, we need to ask about the color of the hematuria and then presence of pain. Usually UTI, there is a dysuria, also urgency and frequency. In urolithiasis, usually there is loin to groin pain, and also in IgA nephropathy, usually it is painless hematuria. Also ask about the duration, which is either acute or chronic. Also ask about the pattern. Is it the hematuria present at the initiation, the terminal, or throughout the urination? Usually, if the hematuria is at initiation, usually the cause usually at the bled at the urethra. If the hematuria at the terminal, usually caused due to the bladder, and if it throughout the urination, usually caused due to the glomerula. Also, as a urea output for presence of the oliguria, pus and the urine in urolithiasis and blood clot in renal tumor. Ask about the associated symptom. Usually you ask about the fever, vomiting, and irritability to rule out UTI, and edema, headache, and shortness of breath to rule out glomerulonephritis. Also, if you suspect post-tracheal glomerulonephritis, we need to ask about recent history of sore throat, urethral infection, and skin infection. HSP, ask about the abdominal pain, arthralgia, rash, and hematochezia. And if we suspect trauma, ask about the history of trauma and recent urinary catheterization, and bleeding tendency played on jaundice in coagulopathy. And also ask about the constitutional symptom and TB contact for TB, renal TB, and malignancy. And if you suspect SLE, ask about the arthritis, oral ulcer, weight loss, alopecia, and weakness. Okay. Next, we also ask about the other relevant history, such as drug history to rule out drug induced, family history of the renal disease, renal failure, and hemoglobinopathy to rule out the hereditary causes of the hematuria. And also ask about the exercise, history of strenuous exercise, diet history, and menses history. Okay, for physical examination, first we need to establish the vital sign, check for the temperature to see fever, and also check for the BP to see any hypertension. Also look for any pallor or jaundice, and don't forget to see for skin lesions such as purpura in henoch purpura, butterfly rashes in SLE, and impetigo in post-tracheal glomerulonephritis. If glomerulonephritis can also present with edema, so don't forget to check for edema. Also, we do abdominal examination. We do abdominal examination to see any pain, suprapubic pain in UTI, and costal vertebral angle tenderness in pyelonephritis. We need to also check for abdominal mass in tumor and vertebral kidney in hydronephrosis. Don't forget to check for external genitalia because we need to see any tear, blood, or foreign body in the genitalia, and also any check for the joint for swelling and tenderness. Okay, for investigation, after we have done our physical examination, first we need to confirm is it really hematuria by doing urine dipstick and UFAM. If there is a really red blood cell seen, so next we need to establish the symptom and sign of the acute nephrotic syndrome that can present with edema, hypertension, and oliguria. If there is a presence of nephrotic syndrome, so we need to do urine protein creatinine ratio, serum urea and creatinine, and electrolyte. Also do serum complement C3 and C4, ASO titer, anti-cetoacidosis O titer for the post-streptococcal glomerulonephritis, and anti-DNase B and ANA for to rule out SLE. To rule out the lupus nephritis. Next, after that, we need to establish whether the hematuria is glomerular causes or non-glomerular causes, in which we can differentiate by UFAM. We can see in non-glomerular causes, the RBC is isomorphic. Meanwhile, in glomerular, the RBC is dysmorphic. And in non-glomerular causes, usually there is no proteinuria, and glomerular usually have proteinuria. So if when we do the UFAM, when we see the causes is towards the non-glomerular causes, so we need to do urine calcium creatinine ratio and urine culture to rule out UTI. We need also do renal ultrasound and Doppler to check for any renal mass, coagulation screen to check for the coagulation lab for blood count and coagulation profile. Also do abdominal X-ray to check for any calculi. And also if we suspect tumor or trauma, we need to do CT abdomen in glomerular causes of the hematuria. So the hematuria is due to the glomerular. So we need to do serum, urine, creatinine, and electrolytes. Also, we need to do 24-hour urine protein to see for any proteinuria, check for complement C3 and C4. Also, check serum IgA to rule out IgA nephropathy, do renal ultrasound, and we also need to rule out the hereditary cause of the hematuria. So we need to test the family members for hematuria, and if you suspect Alport syndrome, we need to do audiology test because Alport syndrome can present with hearing losses. Okay. Okay, next for the management. Management usually we need to treat the causes of hematuria. And usually usually parents can be very anxious when their children is presented with bloody urines. They might think of the tumor, so we need to reassure them and then do a follow up. You can also give supportive treatment like diuretics, fluids, and salt restoration, and antihypertensive. We also need to monitor BP, input output of urine, and weight. I will outline the management of the certain common causes of the hematuria. In acute glomerulonephritis, we need to do strict monitoring of the input-output chart, fluid intake and BP and weight. We also need to give penicillin and start salt and fluid restriction. In henoch-Schwann purpura, it is usually symptomatic. UTI, we need to admit ward and start IV antibiotics. And if IgA nephropathy, it is really not requiring treatment. Okay, so back to my case scenario, a 7-year-old boy presented with a bloody urine for 2 days, which is completely mixed in with the urinary stream, and the color is brown. He also has a previous respiratory tract infection for last 2 weeks, and with no previous hematuria and no family member with the same symptom. On physical examination, he is well, no anemia, no edema. CVS exam was normal. BP was hypertensive. Abdomen and genitalia was normal. After that, we do investigation. The urine dipstick show large amount of the blood and protein, and we can confirm the hematuria. And when we do the urine culture, it is sterile, and when the serum CT was low. So the final diagnosis was post-streptococcal glomerulonephritis. Therefore, we check accordingly. Okay, so that's all from me.
Any question from the team? I think this one is quite straightforward lah. Quite good presentation. Okay, all right, quite clear.
Okay.
Okay, tak ada. Ke tidur belaka semua ni? Okay, alright, fine. Like
Assalamualaikum warahmatullahi wabarakatuh. Can you hear my voice?
yes.
Okay. Next, I will be the last presenter for tonight. I will be presenting about the infant who born inactive. Okay. Sorry for the technical problem. For newborn baby, usually healthy newborn baby, when he or she is being delivered, they will move vigorously, have a good tone, good crying, good breathing effort, and the pulse rate must be more than 100 beats per minute, and the SpO2 will be should be according to the minute of life, such as the uh, diagram that I at the right side. And then for newborn baby, we need to access the uh, general condition of the baby, and then the APGAR score in order to know whether what is the condition. APGAR score is usually used to assess how well the baby tolerated birth and how they adapt to the outside world. Since so for the infant who born inactive, usually the normal physiology will be affected, such as the baby may not move vigorously or may have hypotonia, and they may presented with they may not crying during the delivery and have problem with breathing, and reduce in pulse rate and low in SpO2 level. Sorry, I have some technical problems. Okay, for the chief complaint, a newborn baby boy was admitted to an ICU due to the absence of crying after birth. At 1 minute after birth, the infant has a heart rate of 80 beats per minute, gives irregular gaps, has blue hand and feet but a pink tongue, and has some muscle tone but does not respond when dry. Possible causes for infant who born inactive can be due to maternal causes, fetal causes, and maybe due to complication during the delivery. For maternal causes, um, mother with a GDM or maternal hypertension, hypotensive can affect the condition of the baby during birth, and some um, in in delivery who use anesthesia, heavy sedation can also lead to uh, inactivity of the infant during delivery. And those mother who use drug and has infection during the pregnancy also can affect the condition of the baby during the delivery. For fetal causes, premature baby also can cause inactivity of the infant during delivery, and other fetal causes such as fetal distress, IUGR, metabolic disorder, congenital infection, and congenital anomalies. For the delivery causes, compared to children who born through spontaneous vaginal delivery, cesarean section has can cause more complication to the infant, and assisted delivery such as vacuum assisted delivery can also introduce trauma, and may lead to problems. And excessive other delivery causes such as excessive or prolonged uterine contraction, cord compression such as prolapse cord in shoulder dystocia, and other placenta abrasion, and also excessive suctioning of the pharynx after delivery can lead to baby to be inactive. And the other possible diagnosis can be due to neurological, cardiological, respiratory, and others. For neurological problem, hypoxia, ischemic encephalopathy, neonatal seizure, neurocutaneous disorder, and muscular dystrophy can lead to um, infant born inactive. For cardiological, such as congenital heart disease, persistent pulmonary hypertension in newborn, and patent ductus arteriosus, which can presented in premature baby. For respiratory problem, such as acute respiratory distress syndrome, transient tachypnea in newborn, and meconium aspiration, and other causes such as neonatal hypoglycemia, dysmorphic syndrome, necrotizing enterocolitis, and anemia of prematurity. For history taking, birth history is the most important history that we need to elicit um, in order to know the cause of infant who born inactive, such as intranatally we need to know whether the infant is preterm or term, and then we need to know whether what type of delivery, whether it is a spontaneous vaginal delivery or cesarean section, or it is a assisted delivery. And then we need to know the birth weight of the infant, because infant with low birth weight has more complication than a normal birth weight. And we need to ask whether there is a complication during delivery, such as shoulder dystocia, uh, placenta abruptio, and the most important thing is we need to calculate the APGAR score during the delivery. Antenatally, we need to um, ask about the maternal medical history, such as maternal infection, maternal hypertension, or GDM during pregnancy, and whether the mother had taken some drugs or has drug abuse, especially throughout the pregnancy, and whether it is multiple birth or singleton. And we need to know whether there is a previous obstetric history, and whether there is the baby has fetal distress or IUGR intrapartum. For the family history, we need to ask whether there is any synchronization in the family, any consanguinity, marriage, or any other congenital disease. And for physical examination, in neonate, it is crucial for us to examine the body from head to toe in order to elicit any disorders or problems that can be presented to the baby. For general observation, we need to measure the weight, length, and head circumference, muscle tone, whether there is a presence of reflexes, and we need to um, examine the skin, whether the skin of the baby is pale, jaundice, cyanosis, or whether there is rashes or any birthmark. And we need to um, elicit whether there is some dysmorphic features, such as lucite or simple ear, inner epicanthic fold, and others. And for the for cardiovascular examination, um, we need to uh, elicit whether there is a sign of heart failure, such as tachypnea, hepatomegaly, or whether there is presence of heart murmur, femoral pulses, and we need to palpate the apex peaks. And then we need to check for the back and spine, to check for spina bifida or posterior encephalosis, and we need to examine the hip to test for such as Balo and Ortolani test for developmental dysplasia of the hip. and we need to examine the genitalia and anus, the limb, and for the head, we need to elicit whether there is a bulging of the anterior fontanelle, which may be suggestive of meningitis, skull shape and size, and whether the scalp is swelling or not. And then for the eyes, we need to check for the red reflex of cataract, sclera of jaundice, and then we need to observe the mouth whether there is a cleft palate or cleft lip, and observe whether there is a presence of central cyanosis. And for the chest, we need to measure the respiratory rate, observe any respiratory distress sign, and whether the chest move symmetrical or not. And for the abdominal, we need to observe whether there is any abdominal distension or any hepatosplenomegaly, which can be a sign for heart problems. And for investigation, if the infant is premature, we need to do a thorough investigation um, in order to measure the function of all the organ, whether it is function perfectly or not. And some tests that we can do, such as blood tests, such as MVC, in order to elicit whether there is an infection, and at whether the infant has anemia or not. And for ABG, such as when if we suspect there is hypoxic ischemic encephalopathy, we can do the ABG in order um, to know whether there is presence of metabolic acidosis. Um, and then we can do blood urea serum electrolyte to test the function of the renal, LFT, to test the function of the liver liver function, such as in premature infant, and also those who have hypoxic ischemic encephalopathy. And then coagulation profile can be done as in hypoxic ischemic encephalopathy can be complicated with coagulopathy, and those neonate who suspected to have hypoglycemia, we can do blood culture, blood glucose, and for blood culture, we can do to find the causative agent for the infection. And if we suspect meningitis, we can do lumbar puncture in order to um, check for the CNS analysis. And other imaging that can be done, for example, if we suspect in premature baby, if we suspect acute respiratory distress syndrome, we can do chest X-ray, and to to visualize whether there is opacity, and whether there is presence of air bronchogram in the lung. And for the necrotizing enterocolitis, we can do abdominal X-ray. And for HIE, if we suspect the infant has HIE, we can do MRI or ultrasound. And for infant who has problem in respiration, who has a problem with respiration during delivery, we can check for the ABGAS score. And if usually ABGAS score 0 to 3, we need to do resuscitation. First, we need to check at 1 minute of life. We need to check whether the infant is term gestation or not, has good tone or not, breathing or crying. If no, we need to warm the infant and maintain the normal temperature, position airway, clear secretion if needed, and dry. And then we need to examine again whether the infant is apnea or gasping, and we need to measure whether if the heart rate is below 100. We need to monitor the SpO2 and consider ECG monitoring. And then if the heart rate is below
Okay,
100,
wait. Let me clarify a few things because you are saying a bit wrong lah. First one, ABGAS score does not resuscitation should never depend on ABGAS score. ABGAS score is not for you to determine which baby needs to do resuscitation. No, ABGAS score is just useful for prognostication and further management, like if you want to do cooling therapy and so on and so forth. Resuscitation does not depend at all on ABGAS score. Zero. Which baby you need to do resuscitation based on this algorithm. So this algorithm that you shared, this is actually from NRP7. This is an old one. We already have NRP8. But NRP8 and NRP7 is a bit different only. So it's okay lah for you to present this old punya NRP punya algorithm. That's fine. Okay. So which baby needs resuscitation? Actually, you need to remember 85% of newborn babies will go into normal punya adaptation into extrauterine life. They don't need anything. 15% of babies will need some kind of resuscitation. Out of them, 10% need 10% will recover with just a simple initial step stimulation and so on and so forth. 5% to 10% with just stimulation they recover. And then about around 3% will need up to PPV, positive pressure ventilation. Okay, the presenter mentioned just now at 1 minute you assess. So that is wrong lah. So sepatutnya at birth tu nampak tulis birth yang color grey tu. That is birth. And everything up to PPV that should complete by 1 minute. All these things, all these few steps should be done completely within 1 minute. So at birth, you assess. So there are 3 parameters for you to know whether baby needs resuscitation or not. Whether the baby is firm, a good muscle tone, or breathing and crying. If the baby is firm, good tone, breathing and crying, yes, so baby stays with mother. But if no, any one of these is no, then we need to resuscitate baby. So resuscitation can just mean we do initial steps, which is the warm and dry, position airway, clear secretion if needed, and then stimulate the baby. So this is what we call as initial step. And then we assess again. What is our assessment? We assess whether the baby is apnea or gasping, and also whether the heart rate is more than 100. If no, semua okay, then we can go for we assess lah dia labor breathing ke, dia ada cyanosis ke tak, macam tu. Tapi kalau dia apnea, gasping ataupun heart rate di below 100, then we give positive pressure ventilation. Mana we give bagging, embu bagging ataupun you bag and mask. Then you proceed lah. Next assessment tu heart rate dia berapa apa semua. Go for chest compression and so on so forth. Okay. Faham? Clear? Okay. Alright, boleh proceed.
Okay, doktor.
Proceed. Sudah habis dah?
Sekejap doktor, problem pula.
Sudah. Okay ke?
Sorry for the technical problem. For the preterm baby, if the baby is delivered less than 30 weeks gestation, we need to assess whether the infant is active or breathing, and then we need to uh, we need uh, place the infant in the plastic bag uh, for temperature control and apply nasal high flow 6 to 7 liter per minute and measure the pulse oximetry. If stable, we can transfer to the NICU. And if the infant is not breathing, we need to control the temperature by um, put the infant in the plastic bag and we can give suction if needed and inflation brief, and also we need to uh, check for the pulse oximetry. And if there is no response, we need to intubate and resuscitate and consider surfactant. And then we need to transfer to the NSCU for ventilation. If after the uh, uh, we control the temperature and suctioning is successful and uh, and there is a prompt response, we need to consider a nasal high flow 6 to 7 liter per minute. And if the infant is stabilized, we can transfer to NICU. And if does not stabilize, we need to intubate and consider surfactant.
You dapat mana ni? You dapat mana ni?
And for the case, if
Sekejap.
we
You
suspect
dapat mana tadi tu?
the
Slide tadi tu?
infant has hypoxic ischemic encephalopathy, first we need to secure the airway, and if it is indicated, we need to intubate the patient, and then we need to give adequate ventilation and oxygenation in order to uh, manage the hypercapnia and hypoxemia. And after we elicit, uh, and then we need to treat the underlying causes of the hypoxic ischemia and encephalopathy. And then we need to introduce hypothermia. And if there is presence of renal impairment, we need to give fluid. But we need to make sure to prevent fluid overload, and we need to monitor for cardiac symptom. And then we also need to correct the glucose and the metabolic acidosis by giving bicarbonate. That's all for me.
Where did you get the information about the premature management tadi tu? You dapat mana? Presenter. Mana presenter? Mana presenter? Anyway, okay lah, fine. I'm not gonna wait for her answer. It's wasting my time. So anyway, that's not right lah. Management for premature tadi tu, that's not right. Um, uh, I assume lah. I think
Hello?
probably kat. You dapat mana? Guideline dari mana tu you dapat?
Boleh dengar tak?
Her speaker is not functioning.
Is it? Fine, tak apa. Okay. So what I'm trying to say is, I'm not sure where she got the guideline, but I assume lah, because on her presentation tadi dia ada, if baby is not breathing, dia bagi inflation breath. So inflation breath ni is basically from UK punya neonatal distress guideline. Dia panggil NLS, newborn life support. So this is from UK. So I was trained in UK, and we don't do all this anymore. Yang apa put on nasal high frequency and nasal high flow. We don't generally put that as a guideline macam tu. Nasal high flow is very useful, tapi it is not standard. It is not standard. So in that way, I think that guideline probably is a very old punya guideline lah. So we don't do that. Tapi otherwise yang lain semua I think quite okay lah kot. Okay. Any question pasal this topic of infant born not vigorous ni? Tak ada. Okay lah, alright. I think if there's no other question, let's end our session here. Let's end with tasbih kafarah.